Welcome to This Week in Infectious Disease. This week we're covering 7 notable papers spanning diagnostic overreach and risk stratification, influenza prevention and transmission, and the practicalities of dosing and trial design. Let's dive in. We start with 2 papers that ask the same underlying question from very different angles. When does a positive test actually mean disease that needs treating? In clinical infectious diseases, investigators applied quantitative PCR to urinary DNA from 502 women, 104 with clinically diagnosed urinary tract infection, 354 with non-infectious lower urinary tract symptoms, and 44 asymptomatic controls. Essentially, everybody harbored uropathogen. DNA E. coli was detectable in 97% of women, Enterococcus in 99%, Candida albicans in 94%. Crucially, no PCR threshold separated symptomatic urinary tract infection from either controls or women with non-infectious symptoms. Women with infection did show depleted Lactobacillus crispatus and Einers, and postmenopausal women had higher E. coli and Enterococcus levels with lower Lactobacillus. But vaginal species models reached only modest discrimination in premenopausal women and failed entirely after menopause. With direct-to-consumer and clinic-based urinary PCR panels proliferating, the practical message is that a positive molecular urine panel in a woman without high pretest suspicion tells you almost nothing and will drive antibiotics for symptoms that are not infectious. The flip side is knowing which positive findings genuinely need intervention. And the Apache's cohort, also in clinical infectious diseases, gives unusually direct evidence in anal cancer screening. Among 513 men living with HIV who have sex with men, aged 35 and older, 127 histologically confirmed high-grade squamous intraepithelial lesions were deliberately left untreated and monitored every 6 months for up to 5 years. About a fifth of those lesions regressed within 1 year, 41% within 2 years, and 3/4 of them by 5 years, with no progression to cancer during follow-up. Regression was roughly halved when there was concurrent high-grade cytology or persistent HPV-16 infection at 12 months, and lesions positive for both methylation markers ASCL1 and ZNF582 were the least likely to clear. 5-year regression probability ranged from around 30% in marker-positive lesions with high-grade cytology to about 90% in marker-negative lesions with normal cytology. That spread is clinically actionable. It supports triage rather than treating every high-grade lesion, and it identifies biomarker-positive persistent lesions as the group deserving priority. Our second theme is influenza, where 2 papers in clinical infectious diseases address prevention at the household and the individual level. The Centerstone trial previously reported that treating index cases with baloxavir reduced onward household transmission, but skeptics noted that transmission was defined by test timing and subtype match, which could misclassify coincident community infections. The new analysis sequenced whole influenza genomes from these households, obtaining high-quality consensus genomes for 96% of influenza A and 61% of influenza B specimens, and used phylogenetic distance thresholds to exclude pairs that were unlikely to be true household transmission. Depending on the cutoff, only 10 to 15% of putative pairs were discordant, and applying the most stringent threshold still left adjusted transmission of 9.2% with baloxavir versus 12.9% with placebo, roughly a 30% relative reduction in the odds of transmission. Genomic verification, in other words, did not erode the primary result, which strengthens the case for considering baloxavir in an index case specifically to protect household contacts. Alongside this, a pooled analysis of case-ascertained household transmission studies across multiple United States sites from 2017-18 through 2022-23 examined whether vaccination tempers illness in people who nonetheless get influenza. Among 869 children and 653 adults with laboratory-confirmed infection, vaccinated children had modestly lower daily influenza-like illness and lower respiratory symptom scores, but no shortening of symptom duration. In adults, the pattern reversed. No difference in symptom burden, but earlier alleviation of influenza-like illness symptoms with a hazard ratio of 1.30. The effects are small and the two age groups diverge, so this is a useful counseling point rather than a headline benefit. Vaccination blunts illness somewhat even when it fails to prevent it. Staying with respiratory viral protection, the Journal of Infectious Diseases reports on maternal RSV antibody kinetics in 169 infants born to unvaccinated mothers, including 95 preterm and 53 born before 32 weeks. Counterintuitively, RSV neutralizing antibody half-life was far longer in very preterm infants, around 79 days, compared with about 30 days at term, and that gestational age effect was largely explained by starting titer, since a doubling of cord blood antibody was associated with roughly a 20% shorter half-life for neutralizing antibodies, and about 32% for total IgG1. If the same concentration-dependent decay applies to vaccine-induced antibody, the protection gap between preterm and term infants after maternal RSV vaccination may be narrower than currently assumed, a hypothesis to test, not yet a reason to change immunoprophylaxis decisions. Finally, 2 papers on getting treatment right in the real world. In the International Journal of Antimicrobial Agents, a 3-patient case series describes therapeutic drug monitoring of Aztreonam avibactam in critically ill patients with carbapenem-resistant Klebsiella pneumoniae and shifting renal function. All 3 achieved cure with full target attainment, but continuous vena-venous hemodiafiltration cleared both drugs substantially, and the Oxiris filter produced markedly lower troughs than the HF12 filter, a reminder that the circuit itself is a pharmacokinetic variable. During rapid renal recovery, monitoring-guided dose escalation was needed to avoid underdosing. And in Lancet Infectious Diseases, a review proposes guiding principles for pragmatic randomized trials of tuberculosis treatment, using the PRECIS-2 framework to address broad eligibility, embedding trials in routine services, flexible adherence support, outcome definitions, and risk-proportionate monitoring infrastructure work that determines how quickly shorter regimens actually reach programs. If you only have time for one paper this week, make it the Urinary PCR study in clinical infectious diseases. Molecular urine panels are already reaching your clinic, and this is the clearest evidence yet that they cannot separate infection from non-infectious urinary symptoms, which makes it the paper most likely to change what you order and what you treat tomorrow. Here are the key takeaways from this week in infectious disease. Do not use quantitative urinary PCR to adjudicate recurrent urinary tract infection in women without strong clinical suspicion, because pathogen DNA is nearly universal. In anal cancer screening, most untreated high-grade lesions regress within 5 years. In cytology, persistent HPV-16 and ASCL1 with ZNF582 methylation identify the minority worth prioritizing. Genomic sequencing confirms that baloxavir treatment of an index case reduces household influenza transmission by roughly a third. Influenza vaccination modestly reduces symptom burden in children and modestly shortens symptoms in adults who still become infected. And in critical care, renal replacement circuits and the pace of renal recovery both demand therapeutic drug monitoring for Aztreonam avibactam. That's your roundup for this week in infectious disease. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And if you have a paper you have been meaning to read, upload the PDF or paste any link at audioscholar.cc. We will turn it into audio like this one, in any of 31 languages. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.